Welcome back to Med School Radio. This is Simon in Tokyo. We're listening to some 90s rap, and we're going to be going through some MCQs, some quick questions from Firecracker on the respiratory system. So let's get right to it. Okay, let's start. In patients with COPD exacerbation, what are the indications for non-invasive positive pressure ventilation, or NPPV? The indications for non-invasive positive pressure ventilation are the following: severe dyspnea with respiratory muscle fatigue, increased work of breathing, arterial pH of less than 7.35, or PaCO2 of greater than 45. Okay, next. What are the clinical features which support the diagnosis of pertussis? Okay, we're talking about Bordetella pertussis. The features suggestive of pertussis include a cough lasting more than 2 weeks and characterized by paroxysms of coughing or an inspiratory whoop. So I'm going to look at a little bit more details here. So B. pertussis has an incubation period of 2 weeks, followed by 3 major phases: the catarrhal, the paroxysmal, and the convalescent phase. The catarrhal phase presents similarly to a cold with mild coughing and sneezing. While the clinical course may appear mild, the patient is highly contagious during this stage. The paroxysmal stage is characterized by the classic whooping cough of pertussis, and the cough can induce post-tussive vomiting. The convalescent phase is characterized by a gradual reduction in the severity and frequency of cough. So features that are suggestive of pertussis include a cough lasting more than 2 weeks and characterized by paroxysms of coughing or an inspiratory whoop. Okay, next, what interventions are indicated in a patient presenting with a COPD exacerbation? Okay. Managing acute COPD exacerbations requires the following interventions: supplemental oxygen titrated to goal, SpO2 of 88 to 92%, inhaled bronchodilators, for example, albuterol or ipratropium, intravenous glucocorticoids, and antibiotics if the patient has at least 2 out of 3 cardinal symptoms, and these would be increased dyspnea, increased sputum volume, or increased sputum purulence. So those are the interventions which are indicated for a patient presenting with COPD exacerbation. What are the AIDS-defining malignancies, and what are the oncogenic viruses associated with each? AIDS-defining malignancies include Kaposi sarcoma, which is KS, and this is caused by herpes HHV8. Next, cervical, women, anal, men cancer, which is HPV, and non-Hodgkin's lymphoma, including systemic NHL and CNS lymphoma. What are the 3 most common causes of death caused by chronic obstructive pulmonary disease? Death is most commonly due to respiratory acidosis and hypercapnic respiratory failure. 2. Cor pulmonale, which is rare. 3. Massive, spontaneous secondary pneumothorax. Okay, moving on. Okay, what we're listening to here. Mos Def. Respiration.
All you see is, and then, you know, big, you know, black silver letters that say crime in the city, right?
Okay, what are two side effects of ipraprostenol and iloprost? Side effects of ipraprostenol and iloprost include flushing and jaw pain. Next, what medical management is indicated for the treatment of acute COPD exacerbation that requires hospital admission but not ICU admission? Okay, the choices here are systemic corticosteroids only, antibiotics only, mucolytics, or systemic corticosteroids and antibiotics. Okay, I'm going to read the question again. What medical management is indicated for the treatment of acute COPD exacerbation that requires hospital admission but not ICU admission? A. Systemic corticosteroids only. B. Antibiotics only. C. Mucolytics. Or D. Systemic corticosteroids and antibiotics. So the answer here is both. That's D. Systemic corticosteroids and antibiotics. The neighbors just arrived home, so I'm going to play some tunes just for a bit. Okay, moving on. So let's explain that. Systemic corticosteroids and antibiotics. So to explain the answer here, for an acute COPD exacerbation that requires hospitalization, treatment includes inhaled beta agonists, systemic corticosteroids, and antibiotics. None of these treatments should be omitted. Antibiotic therapy is not indicated for mild COPD exacerbation. If hospitalization is required, then the exacerbation is by definition not mild. Mucolytic therapy, for example, N-acetylcysteine, has not been shown to improve outcomes in COPD exacerbations. Okay, next question. Name two skin findings associated with pulmonary histoplasmosis. Okay, histoplasmosis. Skin findings associated with pulmonary histoplasmosis include erythema nodosum and erythema multiforme. So you remember the details of histoplasmosis? In the lungs of immunocompetent individuals, histoplasma infection produces granulomas, which can appear as calcifications on X-ray. Note that severely immunocompromised individuals with defective cell-mediated immunity, for example AIDS, cannot form granulomas. Skin findings associated with pulmonary histoplasmosis include erythema nodosum and erythema multiforme. Okay, next question. What is the role of anticholinergics in treatment of chronic obstructive pulmonary disease? Inhaled anticholinergic drugs such as ipratropium bromide also act as bronchodilators and decrease symptoms. They have a slower onset of action than beta agonists, but have a longer duration. So one thing to note here is that combined beta agonists and anticholinergic inhalers, such as albuterol, ipratropium bromide, are more effective than either alone. Alright, next question here. Thanks for joining me in this review. What are some treatment options for obstructive sleep apneic patients refractory to Cpap therapy? Okay, patients with obstructive apnea refractory to continuous positive airway pressure and weight loss may be treated with uvulopalatopharyngoplasty, removal of excess oropharyngeal tissues, or tracheostomy. This is the last resort. What are the findings on pulmonary function testing in a patient with COPD? So this is regarding the FEV1, the FEV1 over FVC ratio. What is the VC? The DLCO, the TLC, RV, and FRC. Okay, PFT show an obstructive pattern. Decreased FEV1, decreased FEV1 over FVC ratio, decreased VC, a normal DLCO in chronic bronchitis versus decreased DLCO in emphysema. So remember, there's a normal DLCO in chronic bronchitis and an increased TLC, RV, and FRC. This is because of the trapped air. Next, other than the neoplastic glandular cells, what cell types are increased in number in adenocarcinoma of the lung? Okay, adenocarcinoma of the lung shows increased numbers of both type 2 pneumocytes and club cells, formerly known as Clara cells. So remember those Clara cells and the type 2 pneumocytes for adenocarcinoma. Okay, next, when are inhaled corticosteroids indicated in the treatment of COPD? Inhaled corticosteroids are only recommended for patients with severe COPD and those with frequent exacerbations not controlled by long-acting bronchodilators. Okay, what changes in the lung vasculature result from BMPR2 gene mutation? What patient population is most often affected by this gene mutation? Remember BMP or bone morphogenetic protein 2? Where is this gene mutation significant? Inactivation of the BMPR2 leads to vascular hyperreactivity with proliferation of smooth muscle in the pulmonary vasculature. The patient population most affected by primary pulmonary hypertension is young adult females. So think about this pulmonary hypertension. And I hope you can hear the baby crying in the background. It cries every day, drives me nuts. But it might help you remember this. So I'm going to read a little bit more about pulmonary hypertension here. Maybe I should play some music so you can't hear that baby. Okay, Group 1 or pulmonary arterial hypertension can be further classified into heritable or idiopathic PAH and PAH from diseases that localize to small pulmonary arterioles. Heritable PAH is caused by inactivating mutation in the BMPR2 gene, which normally functions to inhibit vascular smooth muscle proliferation. Inactivation of the BMPR2 gene leads to vascular hyperreactivity with proliferation of smooth muscle in the pulmonary vasculature. The patient population most often affected by primary pulmonary hypertension is young adult females, and amphetamines and cocaine can cause pulmonary arterial hypertension. Next, what is the protease-antiprotease hypothesis with regard to COPD? The protease-antiprotease hypothesis is thought to play a major role in pathogenesis. There are many individual pathogeneses of POD listed below, but they all come down to a relative increase in elastase activity, which breaks down connective tissue in the lungs, as compared to alpha-1 antitrypsin activity, which inactivates elastase. You got to remember that alpha-1 antitrypsin activity inactivates elastase. So says the baby above too. Next, play some music. Nicotine and smoke-derived free radicals cause accumulation of PMNs and macrophages in the alveoli. Activated PMNs release proteases, resulting in tissue damage. Smoking also enhances macrophage elastase activity, which is non-susceptible to cleavage by alpha-1 antitrypsin. Smoking-derived free radicals can disrupt the balance between proteases and antiproteases by inactivating alpha-1 antitrypsin, leading to a functional alpha-1 antitrypsin deficiency. So you're going to remember the important things about alpha-1 antitrypsin. So remember that it inactivates elastase. Okay, one thing I want to remember from this is that there are many individual pathogeneses of COPD, but they all come down to a relative increase in elastase activity. Hey, maybe they're leaving. Let's see. Please leave. Thank you. Okay, next question. What medical emergency can result from local growth of lung cancers, and how does this present? Lung cancer can also cause superior vena cava syndrome, which is a medical emergency. This occurs when local tumor growth compresses the superior vena cava. Obstruction of blood returning to the heart results, causing congestion in the head, neck, and other upper extremities. Superior vena cava syndrome can present with syncope, increased jugular venous pressure, and blue discoloration in the face, arms, and neck. Okay, we're thinking about the local growth of lung cancers. How does this present? Superior vena cava syndrome. The tumor is compressing the superior vena cava. So obstruction of blood returning to the heart results, causing congestion in the head, neck, and upper extremities. So the patient can present with syncope, increased jugular venous pressure, blue discoloration in the face, arms, and neck. Makes sense? Other than smoking, what are the 3 risk factors for COPD? Okay, other risk factors include exposure to pulmonary irritants, alpha-1 antitrypsin deficiency, and asthma. In a patient with central sleep apnea, what determines whether the patient is treated with Cpap or BiPAP? What's the differences here? Okay, central sleep apnea. We're talking about central sleep apnea, not obstructive sleep apnea. Know the difference. Cpap, if hyperventilation is present. BiPAP, if hypoventilation is present. Okay. So there'll be supplemental oxygen and acetazolamide or Diamox. So remember the difference between central sleep apnea and obstructive sleep apnea. What is the cause of cor pulmonale in chronic obstructive pulmonary disease? What's the cause here? Cor pulmonale or right heart failure results from hypoxia. Hypoxia leads to vasoconstriction of pulmonary arterioles, which increases afterload and can eventually lead to right ventricular failure. What is the criteria for determining if an infant has bronchopulmonary dysplasia? Any infant that requires supplemental oxygenation for at least 28 postnatal days is considered NICCHD criteria to have bronchopulmonary dysplasia. What acid-based disturbances can occur in patients with COPD? Okay, chronic respiratory acidosis from increased air trapping and an inability to blow off carbon dioxide leads to chronic metabolic alkalosis, which is indicated by elevated PCO2 and bicarbonate. This is interesting to think about. So first you get chronic respiratory acidosis, then you get chronic metabolic alkalosis. This is indicated by the elevated PCO2 and bicarbonate. Moving on. What is acute respiratory distress syndrome, or Ards? It is an acute lung injury due to an inciting event causing complement activation and subsequent lung damage leading to refractory hypoxemia. Okay, to remember the causes of Ards with the mnemonic. It's a strange mnemonic. It's called Ards. Anyway, so aspiration, acute pancreatitis, air or amniotic embolism, radiation, drug overdose, DIC, drowning, shock, sepsis. Sepsis is a big one. Or smoke inhalation. What is the definitive diagnostic test for diagnosing COPD? And what other findings are helpful in securing a diagnosis? The definitive diagnostic test for COPD are PFTs, or pulmonary function tests. Some supporting evidence for the diagnosis of COPD include anatomical findings of hyperinflation, of an obstructive pattern, and systemic findings of hypoxemia with hypercapnia. Anyway, that was just an experiment there. We're just playing some music, and we are looking at Firecracker, which has been fantastic, along with Osmosis, in helping me prepare for these tests. And certainly reading them out is a great way to remember the main points. So join me next time. We're going to do some more, I think. Thanks for tuning in. Talk to you soon. This is Med School Radio.